Dr. Julie is with us today because this is such an important topic, one that's close and near and dear to my heart. So let's just get into it. Julie, for the people that don't know you or know your background, can you give us just a quick little synopsis of your background, who you are, what you do?
Yeah, thank you. Appreciate being here. I've been a nurse for over 4 decades. I started out, my mom said to me when I was 16 years old, "Why don't you be a nurse?" And I was like, yeah, that sounds like a really good idea. And I just have to say, it's been the best decision I've ever made. So the first half of my career, I spent at the bedside taking care of patients. I worked ICU, critical care in the trauma department, and then I was on the helicopter for 10 years. And then it was time for a change. And so my friend said, hey, why don't you come over and teach with me at the university? And I was like, I like that idea. So now I've been in nursing education for about 15 years.
You're on the helicopter. You must have a lot of stories just for that, but that's probably pretty interesting. Yep.
Yeah, and at my university right now, my students always want to hear those stories and hear what that was like, because some of them, that's already their aspiration.
Hey, that's great. One of the reasons you're here with us today is because you wrote a book, a fantastic book about surviving your hospital stay. So let's talk about that. Let's get into it. You have a mission, right? Let's tell us about your mission and tell us what motivated you to write this book.
What motivated me to write the book, my parents were in a plane accident after I was a nurse for about 10 years. And I was across the country with 5 children, a brand new baby, and a full-time job. And I couldn't be there with my parents. And so it really sparked, please take care of my parents like I would, because I can't be there. And so I've always had compassion. That's just part of my nature. But that took it to a new level. And then when I started in nursing education, one of my professors, I had to choose my project for my master's thesis. And she said, why don't you talk about failure to rescue? And like I said, I had already been a nurse for quite a while. And I'm like, I'm not sure what that is. And when I researched it, it resonated with me because of my parents' situation. They both survived, by the way. But it was really shocking to find the information about failure to rescue, which is patient deterioration that's unrecognized. And then I realized in that research that, and in my own experience, there were so many nurses that did not practice the concepts that we teach in nursing school. And so that kind of became my mission, is to educate more nurses, to spread what we need to be doing in the profession. And I just found that there were so many people that have no healthcare background at all, and yet healthcare is going to touch every single one of us, whether it's personally or with our family or friends. And the other piece of that was learning how many preventable medical errors happen on an annual basis. So back in 1999, the Institute of Medicine published a white paper called "To Err is Human," and they really put the spotlight on preventable patient errors. They estimated back then that it was about 50 to 100,000. Later, when they did retrospective chart reviews, they found, oh no, it's probably at least double or triple that amount. And so we have not really moved the needle in healthcare for patient safety. So the purpose of this book is to save 10,000 lives if I just save one by helping educate the layperson, as well as nursing education for those basics, to really understand more about what healthcare is and how we can be partners.
That's amazing, to save 10,000 lives. And you've got such a big background because, some people just have the bedside experience and some people just have the educational experience, but you've seen it from all spectrums. And, there's a lot of great stories in this book, which are touching, but also kind of shocking. And, from all this, what are some of all your experience, what are some of your biggest ahas, maybe 1 or 2 or 3 of your biggest ahas, if you were going to talk to somebody and say, oh, I can't believe this, right? Or I couldn't believe this when I realized this.
One of the things that really hit home to me is there was a study done back in 2006 of newly graduated nurses. So it was a big N. If you're in research, you understand that, what that means. But It was a big study of over 5,000 newly graduated nurses. So they passed their NCLEX and got their nursing license all the way up to within a year of practice. And what they did was it was a 5-hour exam, so it was hands-on practical as well as written. And they found back then that there was only 35% of these newly graduated nurses in the first year of practice that were ready for practice or safe. A decade later, they repeated it, again, over 5,000 newly graduated nurses across 26 states and 141 different nursing schools. So it isn't a particular school or location in the country. And they found that it had fallen from 35% practice ready down to 23%. Then after the pandemic, and we do know that that pandemic really impacted nursing education, some of those nurses during that time only did video learning and did not have hands-on application. So Kavanaugh, again, I've got all these research articles and evidence-based, so this isn't just my opinion about things, but it was shocking to find that from 35% in 2006 to 23% in 2016, a decade later, and then repeated in 2021, it had fallen to 9%. So we have less than 1 in 10 newly graduated or new nurses that are safe and ready for practice. The other part that's really influential is nursing schools are a bachelor's degree program for a lot of them. A bachelor's degree should be 4 years. A bachelor's in nursing is the second hardest bachelor's degree in the country. First is engineering, and then is the bachelor's in nursing. And we take that 4-year program and condense it into 3 years because the students just want to get out and practice, and we need nurses desperately. So now we're doing a 3-year program, and it's so much information to keep patients safe and keep them alive and help make them better and not worse. So those are kind of the biggest aha moments that I'm like, my goodness, we need to do something different than what we've done because patients still aren't safe. Unfortunately, the preventable deaths are still way too frequently happening. So I compare that number of between 250, 300,000 patients dying every single year, equivalent to 2 Boeing 747 jumbo jets full of people falling out of the air and crashing every single day. That's the shocking part of what those statistics, translate to. And every one of those is somebody's mother, father, brother, sister, right?
It's just shocking because you think about it, if like you say, if you had engineers and they're building bridges and infrastructure and buildings, you're not going to rush them through a program. Or, if I go to some other professional like an attorney or a dentist or, anybody that's going to affect my life, I want them to be ready.
Yes.
And, I've had experience in the hospitals. One of my sons had a lot of different operations. And once you get past the care of the surgery or whatever it is, it's really the nurses that are the most important. They're the ones that you interact with. They're the ones that monitor the patients, that make sure they're safe. And, why do you think that they're trying to, you said they push them through because they just want to be out. Are there other reasons that they're trying to push them through so quickly and they're not ready? I don't want them to learn on the job. I don't want my pilot to learn on the job.
Right. So across the country right now, we're short about 193,000 registered nurse positions. So that in itself we're suffering across the country with healthcare. We don't have enough nurses. I have a friend of mine who's running a major trauma center and a prestigious trauma center on the East Coast. And he said, Julie, it's really desperate out there because in the last 6 months, I've hired 30 nurses and they're all new grads. I have had not one applicant that has experience. And so that's a little frightening that you're in a critical care area like that with trauma, where life depends on us being able to act quickly. That's one of the things I learned on the helicopter. You've got to act quickly to save patients' lives.
With that in mind, what do you do? What does someone, a patient or a patient's family, right, or whoever's in there with them, a lot of it then it comes down to communication, because a lot of people in the past have just deferred to the doctor or to the nurse or to the care. And they're like, oh, you're the expert, you know best, all that stuff. And really, it's okay to question. I mean, it's okay to question. You should question. But it comes down to communication. How can patients and their families communicate effectively, become their advocates for their own health and their care while they're in the hospital?
I think the first part is to understand you are your own best, how do I say this? You understand you or your family's health better than anybody, right? So you have to understand that you're going to be your best advocate better than anybody else. The other thing I would say is that our healthcare system practices in an authority gradient or a hierarchical structure, which what that authority gradient means is that there's fear in asking the higher medical authority a question or questioning, the care that they may prescribe, or even just asking questions at all. We're in that culture of say, thank you so much, and then be totally confused about what's really going on. So we in healthcare have adopted safety practices from aviation. First, it was simulation. They practiced in the cockpit. And then we thought, oh, that'd be great to teach nurses to do, simulation on a mannequin versus, practice there first and then go out. The other thing we adopted was the checklist. So aviation, it doesn't matter if the pilot's flown 5,000 or 10,000 flights, they use a checklist. So surgery centers or operating rooms have adopted now that surgical checklist, because one of the never events that's a major medical mistake that I talk about in the book is called never events. And an example of that is amputating the wrong leg, or removing the wrong breast if there's cancer, removing the healthy kidney instead of the diseased kidney. And you're thinking, oh, that wouldn't happen. It still does. So now we've implemented OR checklists, operating room checklists. The other one is the authority gradient, meaning, hey, the pilot in command was in charge and his word goes. So John Nance talks about this in his book, Why Hospitals Should Fly, but I just loved, because it's so reflective of our healthcare situation, that there was a crash, I believe it was in the not a crash. We'll back up just a minute. There was a flight that was grounded because of weather, and everybody was anxious to get home. The pilot, the co-pilot, and all the passengers. When they were finally cleared, which was about 4 or 5 hours later, okay, everybody get back on the plane, we're gonna leave now, the weather's cleared up. Tower was talking, the pilot said, understand, clear for takeoff. The co-pilot said, no, I didn't hear clear for takeoff, sir, can you double check? The pilot said, well, that's what I heard, and we're leaving, we're going. And there was a mid-air collision and crash because they weren't clear. So after that, now aviation, the co-pilot has just as much say as the pilot in safety. So we need to bring that culture and that ability for conversations between a nurse, a physician, a radiology tech, it doesn't matter. The whole healthcare team should be communicating about how we're going to keep these patients safe and give the best care to our patients.
How does technology come into play for that? Because obviously it makes a lot more sense, because they're just people, right? And they could be having a good day, a bad day. They can be distracted. You never know. And they're just people making decisions. So I know that technology is becoming more and more a part of what we do in healthcare. And let's talk a little bit about how different systems or technology is helping with that checklist, or a second, or a backup, or a confirmation.
Technology is wonderful, and it's come a very long way in the decades since I started into the nursing profession. I would say the caveats for safety would be that the nurse always has to check the patient. If the monitor is showing a rhythm that could be ventricular tachycardia, and that means, something's wrong, we got to go check the patient. It could be artifact, meaning the patient's just moving around. So, or what I've seen, and unfortunately happens, there's alarms on the monitors set for parameters for patient safety. And I know a faculty member that I work with right now has a special needs son and has had several surgeries, and she sits with him at his bedside, and he'll have the alarm, monitor on, and he has some anesthesia reactions, and so he's got respiratory depression that happens a little more frequently or deeper than other patients. But his mom will be sitting at his bedside and the alarm starts to go off because his respirations have slowed down. The nurse will come in the room and shut the alarm off and say, "Oh, I'm so sorry that's bothering you." And she said, "Well, aren't you going to check my son? Because that's what the alarms are for." "Oh, no, he's fine. He's breathing." And so I think in the hurry up mode of not investigating or vigilance when we're surveilling, that's where we can over rely on monitors, or even IV pumps, they can malfunction. And so we always have to, yes, technology is wonderful, but we have to always get back to the patient, put your hands on the patient, and check them. So there are monitors that are great that aren't utilized all throughout the industry. For example, end-tidal CO2 monitoring, which measures exhaled gases, which is carbon dioxide. So one of the stories I talk about in my book is when that wasn't utilized, the patient was receiving opioids for pain after a surgery, and because he was healthy and didn't have any other what we call comorbidities, he wasn't monitored closely enough, and the number one adverse reaction from opioids is respiratory depression. So he wasn't monitored, he wasn't put on an end-tidal CO2 detector, which could have detected that his breathing rate was too slow and his carbon dioxide levels were rising, and his wife came to visit the next morning and found him dead.
I've had experience too many times with monitors, right? And with the parameters. And one of the biggest things for me is like, okay, they just went through this traumatic event, and the best thing they can do is have rest. And I understand they need to come and monitor them, and make sure they're doing okay. But then we do have instances where monitors go off. And so what I've learned over the course of time, and I think you just spoke to that, is it's okay to ask the nurse provider or whoever the provider is to explain what this is, right? What is this tracking? Why is this going off all the time? I've had the instances where, exactly like you said, they came in and said, "Oh, don't worry about it." And I am going to worry about it because I want to know why it's going off. And they said, well, and they said, well, okay, well, we've set the parameters for this point to this point, and actually they can be from here to here. So it's okay if we expand those a little bit. But they don't. I'm the customer, right? We're the customers. The patient is the customer, and it's okay to ask. It's okay to say, explain this to me, because if they're they have more knowledge about it and more informed, I think that they're less afraid of asking questions. And while we're talking about asking questions, I've had some fantastic nurses. I mean, they've just,
Yes.
I call them angels in the hospital. I mean, it's just unbelievable, and it's just great. And I've had some ones that haven't been the best, right? And it's almost like I'm there to do my job. I don't need to become friends with them. I want them to have good care. But, when you have to track them down, and I know they're overloaded in patients, but what do you do when you feel like the care you're getting is not to par, or you have to search them out, and maybe you want to just remind them that we're just not numbers, we're all people, and this is my family or my son and daughter, grandfather. So how do you approach that with someone who's providing care?
I'm going to answer. I think I didn't answer well enough the first question, because you brought this up again, and I think it's so important that you have to ask the questions. You have to advocate. Find the confidence, because if you don't ask or find out the information, it may result in harm, right? So that has to be part of your patient advocacy, whether it's for yourself or your family member. But I would say don't let it rest, meaning if you don't feel right about something, you have to take it up what we call the chain of command. So you start with your nurse. If you don't get resolution, or you don't feel good about a lack of action or the answer that you got, escalated to, there's always a charge nurse. And then there's always a nurse manager on the unit during the daytime usually. There's always 24/7 a house supervisor. So they're a nursing supervisor that their tasks can be, moving a patient out of ICU to the med-surg floor to make room for a critical patient that's coming from the emergency department. But they're ultimately responsible. And then the final level that escalation should go to is the administrator on call. So there's always a hospital administrator 24/7. So if it's after business hours, there's always someone on call. The other thing I'll talk about is rapid response teams. So there is a lot of hospitals that have systems set up where if there's concern before a cardiac arrest, that the nurse should call to get help. So this team usually consists of a critical care nurse with a lot of experience and that has extended training. It could include the ER physician, it could include a respiratory therapist, sometimes a pharmacist. But if the rapid response team is called, they're supposed to come to the bedside immediately, and it is to prevent cardiac arrest. But we don't want it to get to that point, so when the family says, hey, something is wrong, like I said earlier, you know your family member better than anybody. We as healthcare providers and nurses should be listening. But if not, you've got to keep going with that. I talk about the first chapter, the story of Lewis Blackman, a 15-year-old, and his mother later said, I wish I'd have known who I could have escalated to, because she expressed concerns for several days and was never heard.
That's amazing. And there's so many questions here. Let's go first with the if there's a difference between a critical event that you don't plan for and one you don't plan for, right?
Yeah.
So let's talk about a couple of those, but if I'm going for one that I'm planning, like a planned procedure or something, how do I learn what questions to ask or what rights do I have?
So there is something called the Patient Bill of Rights, and it's every healthcare institution has to honor those patient bills of rights, and that is you have access to your medical record, you have the right to get care from a physician, you have a right to be respected. All of those things are kind of the baseline of what is a patient's rights, and if you're family, that includes you in that piece, right? So that's to start with. And then if you're going in, for example, surgery, we know that there's usually anesthesia given. We know that the patient needs IVs. We know the physician should be explaining what the surgery is supposed to be for, what the expected outcomes are, and then what the anticipated length of stay, after the surgery, what should be expected. So ask those so you can plan for sure. Ask, and I think this is really important too, if it's going to be a surgical situation, ask the physician, how many of these surgeries have you done? There is, in the literature and studies, a direct correlation of outcomes, positive outcomes or negative outcomes, based on how many surgeries that surgeon has performed. So while it's great to have a newer, younger physician because they've got the updated training, they don't have the experience, and so again, that should be a mentorship type relationship, which is why they have residency programs for physicians. But ask the questions: who's going to be doing the surgery, who's going to be supervising the surgery, and just make sure that you get answers that you're comfortable with. The other thing I'll say is go get a second opinion. If your surgeon or physician is a good one, they will support that. Say, absolutely, I may not know everything. Maybe there's a newer procedure out there that's less invasive or that would be better for your condition, but you've got to do your own research. And we're so blessed and fortunate to live in the information age where we can find a lot of information. Just make sure it's a credible site if you're going on the internet. But yeah. You're a wealth of information, and in the book there's so many good stories. People like lists, so let's talk about some of the most common medical errors, because I think people don't realize
when things happen, how common this is. We don't get that information. It's not something we're searching out. We don't plan to go to the hospital. If we have a procedure, maybe that's when you start doing all your research. But people don't realize that medical errors happen all the time. So let's talk a little bit about what are the most common ones, and then maybe after that, what we can do to prevent them or help reduce that.
Yeah. So medication errors are the top. I think it's about 35 to 40% of all medical errors are medication errors. So earlier when I talked about patient deaths, between 250 and 400,000 every year, that's just deaths from harm in the hospital. But there's also many more, probably about 3 or 4 times that, of patients that are harmed but don't die. So medication errors will fall into that category too of not everybody dies with a medication error. Although, it was all over the news a couple of years ago about the nurse at Vanderbilt who gave the wrong medication to the patient. That one for sure did die. She lost her nursing license. And again, it was mistakes that could have been prevented by, we teach in nursing school, the 6 rights of medication administration. So is it the right patient? Is it the right medication? Is it the right route? Is it the right dose? Those things are definitely something that should be followed every time a medication is given. If that were the case, this poor patient at Vanderbilt wouldn't have died and lost her life. She got a paralytic medication, was put in a CAT scanner, so nobody monitored her after being paralyzed for 30 minutes, instead of an anxiolytic, an anti-anxiety medication. Big difference. And how that happened was out of the medication system. The nurse just put in VE, was hoping she got Versed, and pulled out vecuronium instead. So it's one of the biggest areas of opportunity. Again, it's paying attention. It's easy to make medication errors. I say that just because that means the vigilance has to be even tighter. Another example I'll give you, when I was teaching in the clinical with students a couple years ago, the primary nurse said, okay, the patient is having leg cramps. I called the physician and got an order. And so we're watching for the medication, and then we're going back to check the physician's order, which the nurse had written. And I said, this doesn't seem right. The medication I was expecting would be quinidine, and what she wrote was, or should be quinine, and what she wrote was quinidine. Well, one's for muscle spasms or cramps, and the other one is a heart medication. And so the order was written for the heart medication, not the correct one. So I went to the primary nurse, who then called back the doctor, who then called the pharmacist. So you have to ask, what is this medication for? What's it supposed to do? Another example I'll give you real quick. There was a patient who had knee surgery. So they're typically given a blood thinner medication in the hospital, and then when they go home, to prevent any kind of clots, because they're not moving around much, and that's another post-op complication potential, is blood clots. And so what the nurse did not do was review the patient's home medications and just said, yes, doctor said continue your home medications. She was already on an anticoagulant because she has a heart dysrhythmia called atrial fibrillation. So she was taking both blood thinners and ended up bleeding internally into her knee, which caused what we call compartment syndrome, which means there was no blood flow getting through, so no perfusion. Came back to the hospital for intense pain. Her leg was already discolored. They had to surgically open the leg to allow the blood to escape. And so there's multiple areas of medications that we just have to understand what they are, what they're used for. So I kind of gave you both answers in that one. Another big one that I focus on is understanding physiological observations of deterioration. So before a patient goes into cardiac arrest, which only 80% of cardiac arrests are preventable, and only 17% of patients that survive cardiac arrest survive to discharge. So that's abysmal right there. We want to stop the cardiac arrest. The only ones we really can't do anything about are the sudden cardiac death, a dysrhythmia, or an acute MI, a heart attack that will kill a patient suddenly. Most other deterioration is observable 6 to 24 hours before deterioration. So that's what I teach the nursing students. That's the pearls in the book to help you. What should we be watching for? And I'll give you a clue that is pretty huge, is respiratory rate. It is the most sensitive and earliest indicator of patient deterioration. So if the respiratory rate is going out of the normal range, because our cells are screaming for oxygen, so our respiratory rate's going to pick up, or our cells are saying, hey, we've got too much carbon dioxide here, and they autonomically or automatically, regulate our breathing. And so that's the earliest indicator. But the research shows that 80% of nurses don't even count respiratory rate. So
yeah, are they looking at O2 saturation? Is that what they're looking at?
They are, but that is a late lagger. So I used to sell this little device. It was about this big. It was an end-tidal CO2 detector, which we talked about a little bit ago, and I would demonstrate it. I would put the pulse oximetry probe on my finger, and I had the little device that showed the numerical and a waveform, numerical value, and it had a little nasal cannula with a scoop that would measure my exhaled carbon dioxide. So I would hold it up and show the nurses in the room that I was teaching, and I did this throughout the hospital. So it wasn't just critical care or med-surg or the NICU or GI lab. It was pretty much all nurses that really didn't understand this concept that well. And I would hold my breath for as long as I could, and I got pretty good at it. And they would see, when I was holding up the machine, my saturation, O2 saturation, never changed. 97, 98, 97, 98. But you could see my end-tidal, my CO2, 37, 39, 41, 43, and they were like, oh my goodness. So I think that was a good visual that we somehow skip over that concept, or they don't remember that concept in caring for patients.
It's just amazing, and these are things that you learn over the course of time, right? I mean, these are things that you just learn that they're not teaching in hospitals. They're not. I mean, if you have students or nurses that are past students, which just goes to show again, if you can change some of the processes on some simple things like just monitoring the right things, that could save people. Let's talk a little bit about the pressure that nurses and providers are under, because you said there's a big shortage. You mentioned that they're hiring a bunch of nurses and they're really not ready. And when they get into the environment, it seems to me that if there's such a big shortage, they're putting a big load on patients. And again, it's I have the biggest respect for them because I've been in this situation so many times. It's like you can't expect that you're the only patient they're serving, because
right.
They're not. But talk a little bit about the caseload that they have. Are there things that can be done to help alleviate that? Not from the patient side, but just from a provider side.
Yeah, and I'm going to say, I guess I should have started out with this. Everyone that usually everyone that gets into healthcare, get into healthcare because they want to help people. Nobody ever intends that they're going to harm people or leave out care that does harm people or make mistakes or errors. So I think the patient load out there is pretty heavy. California, the state I live in right now, does have regulations that regulate the amount of patients that a nurse can take care of. Other states don't have that. And so some states have heavier loads, which just makes it really challenging, because then the nurse is like very task focused, because I've got to give medications, I've got to check my labs. Oh no, this hemoglobin hematocrit was low. I've got to call the doctor. Now I've got to transfuse blood. I've got to check blood sugars. I've got to give insulin. It is a busy time. I mean, I tell my students, get ready and put on your rollerblades, because that's what's going to take. The other kind of sad thing is we do our best in nursing education, but in the 15 years, and I've worked at probably 4 or 5 schools over that time, the students that I connect with after they've graduated and they start working, because I love to keep in touch with them, they'll say, school did not prepare me for this job. And now, after the pandemic and a lot of the students missed key elements, But then boards of nursing approved video because we needed still to get these students through school. But there's a gap there. So hospitals have new grad programs, newly graduated nurses, but in cutting expenses, that's one of the places that some of them cut. And then the other thing they cut is nursing education in the hospitals. So I think there's a real big opportunity to bring essential education and annual education back to the bedside nurses so they focus and remember, oh yeah, if I have a patient with a tube feeding, I need to make sure if I put the patient flat that I turn the tube feeding off, I change their bed, give their care, and put the head of the bed back up. Even just missing, oh, I forgot to do that, can cause harm. One of my clinical coordinators that I worked with at another school, it happened to her grandmother, and her grandmother aspirated and it killed her. We call it aspiration pneumonia. A couple days later, she couldn't recover. So there's no bad or ill intent there. It's just busy. So I think helping families understand how to partner with the healthcare system to ask that question, hey, I understand my mom's head of the bed should be up if she's got a tube feeding, or can you check that IV? It's been beeping. Is it infusing correctly? I went over and touched her arm and it seems like it's swollen and cold. Just helping the nurses. And when you get informed, then you can help because you know what to ask and you know when something doesn't sound quite right. And then you'll know to escalate to get more help if you feel like you haven't been helped.
Right, and I think a lot of it is knowing how to ask, right? And expressing gratitude, I think, and real gratitude, because when we're in procedures with our son Nick, we know and we see, and I watch them because they're just like your rollerblades, hoverboard. I mean, they're just all over the place, right? I've learned about the nursing shoes and which ones are the best because they're on their feet. But I think part of it is, just expressing some gratitude if you're in there for a period of time,
yeah.
And then also, asking in a way that's not combative. Some ways that you just mentioned, things just like, just help me understand, right? Just help me understand, or you mentioned this before, or the other nurse mentioned that before. And let's talk about that. Let's talk about shift change, because if you're in with some kind of critical, condition, and you're in for any length of time, more than a day, or even a day, you're going to have a shift change most likely. And let's talk about errors that occur during shift change, and then we'll ask some other questions about that. Let's first talk about errors about shift change.
Yeah, best practice is shift change at the bedside in front of the patient. Not everywhere practices that, but that's best practice. That means families that are there, or even the patient, when there's an exchange of information from the offgoing nurse to the next oncoming, then there is an understanding, then there's clarification, there's opportunity for questions too, which is great. So it should be pertinent information that's passed between, hey, their lab values were low, the potassium was only 2.9, so we gave a bolus of potassium, whatever that may be, updating, but also including pertinent information that's already occurred. Because it's ideal if the patient's going to be in the hospital 3 days, they have the same nurse, right? Because then you can get to know that patient, and then the family gets to know that nurse. But it doesn't happen that often, only because of varying schedules and, shorter inpatient times in the hospitals. But the really essential information should go back and forth, but it not always does. So they should have notes that they record. Sometimes they'll write it in the chart and then they forget to communicate it, but it could be key information that would help move forward into better caring for that patient. So one of the examples I'll give you, there was a patient that had another knee surgery, and the offgoing nurse forgot to tell the oncoming nurse that the pulses were decreased in that foot and it was cooler to the touch. Well, the oncoming nurse got busy doing other things first because this patient was doing okay. His vital signs were okay. He wasn't complaining of a lot of pain. The epidural was working. but she forgot to go in and assess his foot. So I guess going back to your question about if we're having surgery, what should we expect? Again, where is the surgery and what are they doing? But in knee surgery, for example, this one, if there's a complication, or what we're going to watch for, number one, is perfusion back to that foot, right? And so by the time they figured out, it was the next day that the patient, he kept complaining of more and more pain. And they just figured, it was surgical pain, but it wasn't. It was pain because he wasn't getting perfusion to that foot. And because the nurse missed nursing care and it wasn't passed on that this, hey, alert, the pulses are decreasing, they're not as strong as they were, and the foot's cooler, which should have flagged that to the oncoming nurse, like, I better go back, I better check that quickly or soon and recheck. So that's an example of missed information.
It's amazing from a care standpoint that a lot of people just leave the care to the nurses, right? Leave the care to the doctors. We talked about that. I want to talk a little bit about being your own patient advocate or being an advocate for the patient. Because there's, if you're in the hospital for any number of time, we like to keep a log book, right? Or a log sheet or something, because we'll ask questions like, when does this medication due, right? Because one nurse might say, oh, tell you what, the doctor said you could have it every 4 to 6 hours. And then, so we write down 4 to 6 hours, and then we write down when the next dose should do, or, can we really have it on the 4-hour range? Or, they're supposed to get this particular one at this time. And then when there's a shift change, the other nurse might come in and say, oh, no, it's okay. They had it, when to go search out, right? So let's say they're supposed to have one medication and they've had it and it's been 5 hours. And then the new nurse is nowhere to be seen. If you don't advocate for yourself and you don't know what to, have a record of that, you're going to just wait. And, the next thing you maybe, could be for pain, it could be for something else, but now you're pushing the envelope of the outer range.
Right.
And so let's talk a little bit about, what maybe, things like that. Should patients, keep a little journal or a sheet? Is it okay for them to say, hey, I just want to confirm, even though they did a handoff, I want to confirm what, when they come in, that this needs to be done in this period of time, right? So let's talk a little bit about that.
Yeah, absolutely. You have every right to know what the doctor ordered. And if they say for pain medication, and usually that's correct, it's every 4 to 6 hours on a lot of those medications, it is your right to say, I would like to see the doctor's order, or I would like to know what the doctor wrote, and then just advocate again, hey, we're in that 4-hour window. I highly suggest, as you said, taking notes. There's so much to remember. It gets so confusing. And that really is only your resource when you ask those questions and then write down and have the answers, right? So I think that's a great process to do and highly recommended. And then you have your notes to go back and forth, and then you can ask more questions for clarification. So I'll just add this in there real quick with pain medications. Some nurses are a little more judicious and some are, have different feelings on how much pain medication a patient should get. And they'll put their personal, bias in there or whatever. If it's written or the patient's pain is not being controlled, of course we need to look if there's another reason, like this poor man with his foot and the perfusion. But it is the expectation that the nurse will call the physician and say, hey, this dose of pain medication isn't working. So they are supposed to be the patient advocate. In every state, there's something called the Nurse Practice Act. And number one responsibility is they have to be the patient's advocate. So if that's not happening and you're noticing that as a family member, speak up, because that is their requirement for that nursing license that they carry. You brought up something too, and I wanted to touch on this a little bit about what should we expect as family members, and then going back to your question about common preventable medical harm. And healthcare acquired infections is another really big one. So it is different routes, but number one, what I could say, different routes of transmission. Number one is hand washing. So healthcare, whether they're physicians, respiratory therapists, it doesn't matter, phlebotomists, nurses coming into your room, every single person coming into the room that's going to touch the patient should wash their hands. Not just put on a pair of gloves, they need to wash their hands. That is the transmission, the easiest way to prevent infection. And so that's another big one. As a patient advocate, you can just say, hey, doctor, yes, doctors, you need to call them out too. Say, I understand that you need to wash your hands to protect my wife, my son, whoever. Can you please do that before you come over here?
Will they be offended?
You know, if they are, tough. Would you rather offend them or potential of infection happening to, your family member? So they need to get over it, because the more informed the general public is, healthcare is going to have to step up and do what they're expected to do and not take shortcuts.
Right. Yeah, and you know what? You're in a hospital, and they have, if you're in the patient's room, they have wash your hands, right? They have to wash your hands if you're in the room, in the bathroom. So, and I've been in there a lot. The nurses will come in and may change their gloves. I don't see them washing their hands. A lot of times they'll use antiseptic or something, to kill germs. I don't remember really any doctors doing that when they're making the rounds. They come in, so it's, and you can do it in a nice way. You can do it in a nice way. Like, I don't know how clean that door is, but can you just wash your hands really quick? Yeah, it's like. And they'll probably go over and do the same thing. They'll just, and most of the doctors I know would be like, oh, okay, but you're right, because they know they're supposed to do it. Yeah. We've talked about so many things. If there was, and you might have talked about these, but I like to summarize them anyway. If there were 3 top takeaways you would want someone to know about, advocating for themselves, how to prepare, whatever, from either a patient or a provider standpoint, what are the top 3 takeaways you want people to go?
I would say
it goes along with your mission to save 10,000 lives.
Yeah, absolutely. Become informed. There's no reason nowadays to not know something. I think the biggest thing is most people don't know they need to know until they're in that situation, and then they're like deer in the headlights because they feel very vulnerable to the healthcare system. As we talked about before, the authority gradient, doctors have had 8-12 years of education, nurses have had 2 to 4 or more years of education. They should know. Yes, they should. But we have to rely on ourselves to advocate. So become informed, I think, would be the first one. And find that confidence in communication, as we've talked about. Do it with gratitude. It's how you say it sometimes and how it lands. But I know that all of us who have healthcare background, I know I would appreciate, hey, can you come check my dad? He's just not quite right. And over time I've learned when they say that, something's going on. It isn't just like, and so become informed, advocate for sure, and understand the various ways that you can be a partner in healthcare for your own or your family members, because it's vast. There's a lot going on, and it's fast-paced many times. But even just becoming informed to know, hey, what was my dad's lab values this morning? I know yesterday, his potassium was low. What is it today? Or his hemoglobin was borderline. Is it better today? And then they come back and say, oh, yeah, it's not so great. Oh, well, what's the plan? Ask what the plan is. Ask for the results. Oh, another big medical error is diagnostic errors. Some of that is just lack of communication. So in the book, there's another story about a man who had a tumor. They thought it was benign, had the tumor taken out in surgery. Family assumed because they didn't hear anything that it must have been benign. 6 months later, he's got another headache that won't go away. Did another CAT scan. The tumor was back. It was malignant, and he died 4 months later. And then they went back and realized, oh, the first tumor was malignant. So you can't assume because you don't hear anything that everything's okay. You have to do your own follow-up. A doctor may have 500 patients, I don't know, in private practice or whatever. But again, our family member and our loved ones and our friends are our priority, and that interest base, that's not the right way I want to say it, but we're concerned about a small number, whereas, nurses are taking care of quite a few patients and they've got a lot going on. But our focus is going to help them focus on how we can help those patients stay safe and not have harm occur in the hospital.
Right, and think about it. Think of it as we're the customer, right? I mean, it's one of the few places where we don't think about that. But if you're in the facility yourself, or you've got a family member, they're the customer, and so it's okay as a customer to be receiving care, to ask questions, to be informed, to all those things that you mentioned. It's just so important because one of those 10,000 lives that you want to save could be one of your family members, and just by simply asking some questions, knowing what to ask, being a little more bold, it can make a big difference, and especially if it's early on. So
Absolutely.
This has been great. If people want to learn more about you or your book, where do they go?
My website is drjuliesiemers.com. That's drjuliesiemers.com. And then the book's on Amazon. If you just search Julie Siemers and Survive Your Hospital Stay, you'll find it. So I hope everyone reads it, because I think my son just finished it and he said, "Mom, I'm not being biased, but oh my goodness, I had no idea. And I feel so much better if I have to take my wife to the hospital or my daughter to the hospital. I feel empowered to ask questions. I know kind of the categories I need to look at, what questions to ask." But he goes, "Everybody needs this." And I feel it too. I mean, even educated people that have some healthcare background. A couple of my students that are ready to graduate read it, and they said, "Now we feel better prepared because we know if our patients are becoming informed, they're going to hold us, and oh yeah, these are pearls and concepts that I need to remember." But again, nursing school is like drinking from a fire hose, right? There's so much. How do we distill it down to those pillars of health assessment that I call it? So I try to help the students refocus back on those really pertinent things, but that's kind of what we cover in the book. So hopefully an app to come. That's what I'll be working on next. That patients can have that information at the touch of their fingertips on their phone. So hopefully that'll be coming. And then on my website, I'll start posting resources, blogs to help. And so there should be more coming that will be really helpful for people to become informed and to learn from other people. The other thing, the book talks a lot about the stories, and I think that will help people. But I also want on the website people to start sharing what happened with them, whether it be positive and good, or what they learned from their experience that was a challenge or maybe harm occurred, that everyone can learn from. It's just reading other people's experiences. So that's coming too.
Awesome. And testimonials from your child and your students, it can't get any better. It can't get any better than that. So again, thank you for being with us today. And again, if anybody wants to pick up her book, go to Amazon. It's going to be well worth it, and you'll just learn something. So thanks again.
Thank you. Appreciate it. Bye-bye.